Hello, my name is Paul Flynn and welcome to episode 5. This is the second part of this section and we're going to explore more of the patterns related to persistent or chronic pain. As a brief recap, in the last episode we started this section looking at why pain sometimes persists for some people but settles for others. Now we've looked at several patterns researchers have identified when studying large groups of people with persistent pain. So it was things like stress, anxiety, mood, and also how pain is interpreted and how the nervous system can become more sensitive over time. But as we said very clearly in that episode, these are patterns, not rules. They don't mean that everyone with persistent pain fits neatly into one of these categories, and they certainly don't mean that the pain is caused by a person's thoughts or behaviour. They simply reflect patterns that appear more often in research when scientists compare groups of people whose pain settles versus those whose pain continues. Or in the case of certain chronic pain conditions such as fibromyalgia, where pain develops without any obvious trauma or injury at all. Now in this episode we're going to expand that conversation a little bit further, because researchers have also identified other factors that appear more often in people whose pain has become persistent. Some of these are related to demographics, so things like a person's background, their circumstances, or aspects of their lifestyle, and others relate to an aspect of their medical treatment itself. And the main example we're going to look at is that of patients who have undergone surgery. So again, just to reiterate, we are not implying causes or labels, and we're not assigning responsibility for someone's symptoms, but we're simply observing patterns that research repeatedly observes when studying persistent pain. So again, let's jump right in. So one of the first areas researchers often look at when studying any health condition in general is demographics. Now, when researchers talk about demographics, they simply mean the characteristics of groups of people. So things like age, sex, background, work, or life circumstances. So when they study large populations, certain demographic patterns appear more often in people living with persistent pain versus those that don't. So, for example, one of the most consistent patterns seen across many countries is the relationship between chronic pain and socioeconomic status. And what we mean by this in simple terms is that people from more disadvantaged social or economic backgrounds tend to report higher rates of persistent pain or more frequent rates of persistent pain. Now, this pattern appears across many different pain conditions and has been observed in multiple countries. And more broadly and importantly, the link between socioeconomic circumstances and health is one of the most consistent findings in medical research. Now, what we mean by this is that across many areas of health, such as heart disease, diabetes, mental health, and even life expectancy, people from more disadvantaged backgrounds tend to experience poorer health outcomes. Now, this isn't groundbreaking and it's well-documented research. So needless to say, chronic pain numbers don't escape this link either. And in fact, research has shown that people from lower socioeconomic backgrounds may be roughly twice as likely to develop chronic pain after an injury compared with those from more advantaged areas. Now again, it doesn't mean that social or economic status causes your pain, but it does suggest that the circumstances people live in can influence health, including the likelihood that pain becomes persistent. So if we're saying that this link is clear, the obvious question is why? So researchers have proposed several possible explanations for this. So for example, people in lower socioeconomic groups are often more likely to work in more physical demanding jobs. So manual labour, repetitive work, lifting, or long hours on their feet. And these types of work naturally carry a higher risk of musculoskeletal strain and injury in the first place. But there's also the financial pressure and job insecurity, which may also increase stress levels. And we know from the research presented in previous episodes that this stress can influence pain sensitivity. It has also been proposed that work patterns also play a role. So shift work or irregular hours can disrupt sleep, and poor sleep is strongly linked with increased pain sensitivity. And this is something we're going to deal with in detail in later episodes. A well-documented factor is also access to healthcare in more disadvantaged areas. So research shows that people living in more deprived areas are more likely to experience longer waiting times for treatment and are less likely to be seen within target timeframes. And when we look locally, the scale of waiting times becomes very clear. So for example, in Northern Ireland, over a quarter of the population is currently on a hospital waiting list for something. And many patients are waiting for over a year for treatment. Now, in some cases, people wait significantly longer than that. But in response to these delays, an increasing number of people are choosing to pay for private care. And this can further widen the gap between those that can access treatment quickly and those who can't. And certainly there would be significant potential that these health inequalities could link with the higher rates of chronic pain documented. What is interesting, however, is that when we talk about socioeconomic circumstances, we consistently see certain patterns in health behaviours that differ across most and least deprived areas. So, for example, rates of smoking, unemployment and substance misuse and lower levels of educational attainment tend to be higher in more deprived areas. So, with smoking alone, around 22 to 25% of people in the most deprived areas of the UK smoke. And that's compared with roughly 8 to 10% in the least deprived areas. Now, we see similar patterns when we look at unemployment levels and rates of substance misuse, which are also consistently higher in more disadvantaged populations. So, education levels also show a similar pattern. People living in more deprived areas are statistically less likely to complete higher education. So what we often see is that many of these social factors cluster together in the same populations, and in this case, in the most deprived areas. So what's really interesting is that when researchers then examine these factors individually, many of them are also associated with higher rates of persistent pain. So, for example, smokers appear to have roughly a 30 to 70% higher risk of developing chronic pain compared to non-smokers. And it's no different with employment status, where the research suggests that chronic pain can be 2 to 3 times more common among people who are unemployed versus those that are employed. So when these factors, things like smoking, unemployment, lower levels of education, are more common in certain populations, and those same factors are linked with higher rates of chronic pain, it helps explain why persistent pain is also reported more often in those groups. But it is also important to emphasize again that these are proposed explanations. We are clear that the link between socioeconomic class exists, but the mechanisms are way more complex than that. And as with all aspects of persistent pain, it's likely that it's due to multiple interactions over time. So when researchers observe higher rates of persistent pain in more disadvantaged groups, they don't interpret that as a simple cause and effect relationship. Instead, it reflects a broader reality that health is shaped by many aspects of life. It does, however, show potentially how these risks can come together within the same population groups. Now, another demographic pattern that appears consistently in pain research relates to sex, and in other words, biological differences between men and women. So, across large population studies, persistent pain tends to be reported more often by women than men. And in many studies, around 20 to 25% of women report chronic pain, compared to roughly 10 to 15% of men. And we see similar patterns across several specific pain conditions. So, for example, fibromyalgia, which we mentioned already, is estimated to affect roughly 2 to 4% of the population, and about 80 to 90% of those diagnosed are women. Now, migraines show a similar pattern, and it affects roughly 15% of the population overall, but women are about 3 times more likely to experience migraines than men. Now, these kind of differences appear across several pain conditions, including back pain, migraines, fibromyalgia, and chronic widespread pain. Now, the important question again is why? And the honest answer is we don't fully know. Now, researchers have proposed several possible explanations for this difference, and some of it relates to biology. So, for example, hormones may influence how pain signals behave in the body, and hormones change across the menstrual cycle, during pregnancy and after menopause, and these changes can affect how sensitive the body is to pain at different times. The immune system also may play a role in this picture as well. So the immune system helps the body respond to an injury and inflammation, and some research suggests that these responses may differ slightly between men and women. Because inflammation and pain are closely connected, this could influence how pain develops or settles over time. Now, researchers have also looked at pain sensitivity itself. So, in controlled laboratory studies, when the same pressure, heat, or cold is applied to different people, women on average tend to report pain slightly earlier than men. Now, that doesn't mean that women are less tolerant of pain. It simply shows that the nervous system may respond differently to the same stimulus. But the important point in this is that the differences between individuals is far greater than the average difference between sexes. But researchers have also considered social factors when looking at the difference in sex. So, for example, women tend to live longer than men and are therefore more likely to experience age-related conditions such as osteoarthritis, which increases the overall prevalence of pain. And there may also be differences in how healthcare is accessed. So, for example, in many countries, women are more likely to seek medical advice for symptoms, which may mean that pain conditions are reported and recorded more often in research. And there may also be differences in how symptoms are interpreted or discussed. So some studies suggest that men may be less likely to report ongoing pain or seek help for it, particularly for musculoskeletal problems. But again, none of these explanations fully account for the pattern on its own. So while researchers consistently observe that persistent pain is reported more often by women, the exact reasons for that difference remain unclear. So the key point here is that researchers consistently observe a difference between sexes in the prevalence of persistent pain, but the mechanisms behind that difference remain an active area of research. Now, so far we've looked at two demographic patterns that researchers consistently observe. So we've discussed the link between socioeconomic circumstances of chronic pain, and also looked at some of the research exploring differences between men and women. Now, another demographic factor researchers often examine is body weight. So across large population studies, chronic pain is reported more frequently among people who are overweight or obese. And for example, people living with obesity appear to have roughly 2 to 3 times higher rates of chronic pain than people who are of normal weight. Now, researchers again have proposed several possible explanations for this. Now, one possible explanation is simply the extra load placed on the body. So when we climb stairs or stand for long periods, our muscles and joints are constantly carrying our body weight. So when that weight increases, the forces passing through these joints and tissues increase as well. And over time, the additional load may contribute to a strain within the system and increase the likelihood of pain developing. Now, researchers have also suggested that body fat itself can influence pain. So your fat tissue in your body, it's not just a place where the body stores energy. It can also release substances that affect how the body reacts to irritation and swelling. And those interactions are closely connected with pain and pain sensitivity. And on top of that, lifestyle factors also contribute. So people living with obesity are statistically more likely to experience sleep disturbance, reduced physical activity, and other health conditions that may influence pain sensitivity. But again, the relationship is not straightforward. In many cases, it's important to recognize that many of these relationships can work in both directions. So, for example, some living with persistent pain may gradually become less physically active, and over time that can contribute to weight gain. And in the same way, long-term pain can make it difficult for someone to continue working, and in some cases, people may have to reduce their hours, leave employment, or even medically retire because of their symptoms. So when researchers see links between things like obesity, unemployment, and chronic pain, it can sometimes be difficult to know which came first. But what the research shows clearly is that the higher body weight is associated with higher rates of chronic pain, but exactly why that relationship exists is still being studied. So what we've now introduced is 3 more factors that research has linked with higher rates of persistent pain: socioeconomic circumstances, differences between men and women, and body weight. And as you're probably starting to realize, is when scientists study chronic pain across large populations, the picture quickly becomes very, very complex. These risk factors are wide-ranging. They involve biology, lifestyle, social circumstances, and health behaviours. And the research in this area is still evolving. But so far, everything we've talked about relates to characteristics of people or the circumstances they live in. Researchers have also looked closely at a very different type of risk factor, the medical treatment itself. And one of the most interesting examples of this is people who have undergone surgery. So, as we know, and as is obvious, surgery is designed to fix problems in the body. But interestingly, research shows that some people continue to experience pain even after surgery has successfully treated the original problem. And this is known as persistent post-surgical pain. Now, depending on the type of surgery, studies suggest that somewhere between 10 and 30% of patients report ongoing pain months after an operation. And for some procedures, the numbers can even be higher. So for example, persistent pain has been reported after operations such as hernia repairs or knee replacements, even when the surgery itself has technically been successful. So again, the obvious question becomes, why? If the structural problem has been treated, why does pain sometimes remain? And this is where what we discussed in earlier episodes again becomes important. Because research shows that the way the nervous system responds before and immediately after surgery may influence whether pain settles or persists. So for example, it is shown that people who experience really high levels of pain in the first few days after an operation are significantly more likely to develop persistent pain months later. In simple terms, the stronger the pain response earlier on, the greater the chance that the nervous system may remain sensitive for longer. And that links closely with what we discussed in earlier episodes. pain is not simply a signal coming from damaged tissue. It's also influenced by how sensitive the nervous system has become. And if the system is already on high alert, perhaps because someone has been living with pain for a long period of time before the surgery, that sensitivity may not switch off immediately once the operation is over. And this factor of how long pain has been present prior to surgery is important. So many people live with significant pain for years before an operation becomes an option. And think about someone waiting for a knee replacement, for example. They may be living with severe pain for several years before the surgery finally happens. Now, during that time, the nervous system has been repeatedly exposed to pain signals, which is what we discussed in episode 3 and 4, the ability of the nervous system to learn from that experience. So by the time the surgery finally takes place, the joint may have been repaired or replaced, but the nervous system may already be operating at a much more sensitive state. For many people, the system settles again after recovery, but for some people, the heightened sensitivity can remain. So it doesn't mean that the surgery has failed, and it doesn't mean that something has been missed, but it can create a significant amount of anxiety and frustration for the patient, particularly if they're not given a clear explanation of why their pain is continuing. And in some cases, people may feel dismissed when they raise these concerns because from a clinical perspective, everything appears to be fine and the surgery has gone well. But as we've already discussed, increased anxiety and uncertainty can influence how pain is experienced and can affect pain sensitivity. And this issue with ongoing post-surgery pain can often simply reflect how complex the pain system can be. So the surgery may successfully fix the structural problem, but the nervous system may take longer to reset. And this is another example of how persistent pain rarely comes down to one single cause. It usually reflects a combination of factors that have built up over time. And this issue is not the same across all operations. So some procedures are much more likely to be followed by persistent pain than others. So, for example, studies suggest that around 20 to 40% of people report ongoing pain after certain types of breast surgery. And after lung or chest surgery, the numbers can even be higher, with some studies reporting pain in around 30 to 50%. So even with common procedures such as a knee replacement, operations are often performed specifically to relieve pain, and around 15 to 25% of patients still report ongoing pain months after the surgery. And of course, as we know, many people live with significant pain for a long period of time before these operations take place. And we've spoken regarding waiting lists in Northern Ireland for hip and knee replacements, where the wait times can be significantly longer than 1 year. So while surgery can be extremely effective at treating structural problems, it does not always guarantee that pain will completely disappear afterwards. And as we've stated, for some people the challenge is not just the pain itself, but the confusion that can follow when the surgery is considered technically successful, yet the symptoms continue. So, this concludes this episode and enters even more factors that have been shown to influence chronic pain. The last point on surgery, however, does lead nicely into our next episode, because the way persistent pain is explained, or sometimes not explained, within the healthcare system can have a major impact on how people understand and manage their symptoms. We're going to continue this segment of the story in part 3 of this section in the next episode. We're going to discuss the patient journey and the profound effect it can have on patient outcomes. The last 2 episodes largely relate to persistent pain to the individual and the circumstances that they live in. The next episode will shift more to the external influences that can shape the pain experience and the research that exists to try and make sense of it. I hope you can join us, and take care.